discussion. Don't
Thank you,
be
Dr.
afraid of the well.
Thank you, Dr. Sajjan, for the kind introduction. At the outset, let me thank Dr. Kala, Secretary of the Region of Dynamic Club, and my wife, Dr. Thomas Syrian, and Dr. Jyoti for this opportunity. I congratulate Dr. Thomas Syrian for making this year's Noel Moniz oration slightly different and calling a non-ophthalmic specialist and an orator, great orator, to be the oration awardee, especially since the magnitude of the profile of Dr. Noel Moniz does not limit to ophthalmology. And I still remember the first Noel Moniz oration when it started. It was Dr. Thomas Syrian who was the secretary, and I was fortunate enough to be the scientific committee chairman, and Dr. Giridhar was the president at that time. Now, I'm lucky to be talking after Dr. Jyoti, who explained the basics of ultrasound very clearly, and Dr. Anil, who spoke about pentacam. So that makes my life easy. And basically, a scan is an investigation which measures the various dimensions of the eye and the interrelationship between them, and thereby determine the ideal intraocular lens power. By this I mean the axial length, the AC depth, the lens thickness, the effective lens position, etc. So essentially it consists of a keratometry reading along with the ultrasonic measurement of the axial length of the eye. And in case of optical, then it becomes laser based. So initially you have to check the keratometry because due to very specific obvious reasons, because before once you measure the axial length, except in case of optical, you meddle with the cornea, and so this has to be done first before the axial length, and you can use a manual keratometer, which is still a golden standard. The autokeratometry, which can be by the ARK or which is incorporated into the AL Master or the Lens Star, the optical biometers, or you can use a topography, which can be either placebo-based or elevation-based topography. Manual keratometry, we've all done this. Basically, you align the Myers, the plus and the minus symptoms, the signs, and then you get the correct. We usually use the Bosch and Lomb machine, which is cheap but still accurate, still fall back on. Automated keratometry, like I said, it can be in an autorefractive keratometer, or in one of these optical biometers. So basically here the image is captured by a photosensitive device, and it is fast and reasonably accurate, and the zone of measurement is the central 3 mm zone. Coming to the axial length measurement, it can be optical or ultrasound based. So ultrasound based, it's been explained by Dr. Jyoti. The ultrasound probe has a piezoelectric crystal which emits the ultrasonic waves. It travels from the anterior cornea to the internal limiting membrane and back. The time taken is extrapolated into the axial length. And here we have to note that every 1 mm error in the axial length can lead to 2.5 mm error in the post-op refraction, and you have to be extremely careful. So how are you going to be careful about it? So every time you do it, or at least once a week, you have to calibrate the ultrasonic probe. So basically, every ultrasound machine, biometer, has a small cylinder in that, which can be used to calibrate the machine before doing every scan, or at least the beginning of the day. And basically, you also have to look at the echoes from the cornea, the anterior lens, posterior lens capsule, and the retina, which should be of equal height, and then there should be an attenuation because of the orbital fat. So you should take a minimum number of at least 5 to 10 readings, and use the gain, the least gain, which gives you a good reading. It shouldn't be kept at the maximum height. So this is the initial spike. A is the initial spike. The B is the anterior lens capsule, posterior lens capsule, the retina, the sclera, and then the attenuation. So this is how it is. All these should be of equal height. And regarding the gain, you should keep it as low as possible to get a good spike. If the spikes are not obtained properly, then you have to increase this thing. Keeping it very high will give you artifacts. Immersion technique is the way to go. Contact biometry is almost obsolete because, as we know, it can cause indentation and it can give you false reading, shorter readings of the axle length. So the only problem is it requires the patient to be immersion technique. The patient should be supine, and the probe doesn't touch the cornea. It goes through a water bath. So there is no individual variation, there is no indentation, and you use a Prager shell, something called a Prager shell. So it's a water bath. It's placed on that. So this is essentially how it is. The probe reaches only till here, and there is a water bath. This is kept on the cornea, and this water column is the one which gives you the reading. And here you have an extra spike. This is from the probe, and the corneal spike and the probe spike is not the same. There is a distance. And in special cases, for example, a posterior staphyloma, if you have a posterior staphyloma, it may be off the macula, so you may get a falsely larger length if it is off the macula. So in these cases, a B scan with an A scan vector will be a great idea, so that you pass through the macula. And all these conditions like a retinal detachment, all this will reduce the axle length. So again, using a scan vector in a B scan will be a much better idea. And vitreous lesions will show us low amplitude spikes here. And a dense cataract, here is the only reason where we should keep maximum gain, because we may not get it. Silicone oil, again, it will attenuate the speed of the ultrasonic wave. So depending on how many centipoise this thing, you will have to make adjustments. Optical biometer, we have the most common ones are the IOL master and the lens star. So both use diode lasers of different magnitude, and IOL master uses the partial coherence interferometry, and the other one low coherence optical reflectometry. And IOL master, the corneal points, it's a hexagonal 6 points in a diameter of 2.3, whereas in the lens star there are two circles in of 32 points, and again it is the first ring is 1.65 and the other one is 2.3, and between the two, both are good. Lens star actually uses optical biometry to measure the anterior chamber depth, whereas the IOL master uses the slit imagery. And the ACD measurement in the lens star is from the endothelial surface, and the two sets of reading are taken. In IOL master 700, since it is a OCT based measurement, axle length measurement can be better, especially in thicker lenses. And unusual eye geometry like tilted or decentration of the lens can be detected in this. And it uses the swept source OCT in the image measurements. So basically, these take the measurements from the RPE rather than internal, and the specificity is around 0.1 millimeters. And limitations is making the patient sit is a problem. Coming on to the effective lens position, the IOL formulae. Basically now what is more important is the effective lens position, which is being corrected in the newer formula. You can have the theoretical or the regression formula. So basically theoretical, the regression goes back, collects data from the post-operative results and gives us this thing. So you have the SRK1, the SRK2 is the second generation, and the third generation are much better, the Holiday SRKT and the Hofer Q. And the fourth generation Holiday 2 is very important, very good. So basically this is the measurement. The power is A constant minus 2.5 into the axle length and 0.9 into K. So as we know, every diopter, every millimeter of axle length can give you 2.5 diopter error, and every keratometry, every diopter can give you 0.9. So this is okay. This is all we use the modified SRK2. This is the modification of the SRK, And we have the SRK-T formula, which is reasonably good in immetropes and mild to moderate myopes also. The Holiday is a third generation and it's enhanced. Basically, these new formulae become good because the effective lens position is adjusted. The Hoffer-Skew formula is good for short eyes. Aegis is good for myopic eyes as well as in post-refractive surgery eyes. So this is anything below 20 hyperopic eyes, Holiday 2 or Hoffer-Q. 20 to 22 millimeters Hoffer-Q is best. 22 to 24 SRK-T and Holiday. 24.5 to which is Holiday, and more than 26, both these work very well. So Barrett's Universal 2 is more accurate than any third generation formula, one of the best bets. And in short eyes, you can use Aegis, Hoffer-Q or Barrett's Universal 2. In a long eye, you have Olsen's, Aegis and Barrett's Universal 2 give best results. And long eyes, SRK-T and Holiday can be used with Koch-Wang's axial length adjustments. So in nanophthalmos again, Hoffer-Q and Aegis can be used. And post-refractive surgery and keratoconus eyes again use formulae which use the axial length rather than the corneal measurements to predict the effective lens position. Silicon filled eyes, we can use a factor of 0.72. High myopia, again I said IOL master can be used or a B-scan with A-scan vector. Pediatric biometry, you will have to undercorrect depending on the age. And in post-refractive cases, there is a change in the Bell-Strand ratio. So again, go for measurements formulae which use axial length to calculate the anterior chamber depth. So the solution comes in total keratometry. So rather than going for the older methods like the clinical history, now we can go for the total keratometry. So this is basically either we can use the IOL Master 700 or you can use the Pentacam with the correction. And this is how you should go ahead with that. And you have online calculators also. So myop post-refractive surgery, you can use Aegis formula, Shama's or Topper True-K or the Barrett's True-K. At the end of the day, you have to use a single instrument preferably for all this so that you can get consistent results. And use the correct formula and always have your IOL constant, personal IOL constant, which is you go back, see all your post-operative refractive balances, and then use your make your personal A constant for each IOL. Thank you very much for your patience.
Thank you, Dr. Sony.